I don't.
Mine,
Are we
yeah,
live then?
mine doesn't do the music.
Yes.
Okay, so we are live, and this is Senate Health and Welfare. We are on Friday, February 9th. And this morning, we're picking up H 469. It is an H bill, but I understand that it has some time limitations, so for us to look at before crossover. So Jen, why don't you walk us through the bill, give us the introduction,
All right.
and we'll move ahead.
Great. Jennifer Carby, Office of Legislative Counsel. So I thought what we would start with today is really just an overview of advanced directives, if that works, because I think they may be a new concept to some of you. I don't think we've talked about them in this committee this biennium. And so I have a presentation that I had done for House Human Services last year that I thought would be helpful to do here. So, all right, there we go. So advanced directives. So starting with, what is an advanced directive? An advanced directive is a written document in which an adult with capacity, who is referred to in the statute as the principal, can do a number of things. They can appoint an agent to make their healthcare decisions for them if the principal is not able to make their own healthcare decisions. They can express types of healthcare that the principal does or does not want to receive, which can be things like, do they want to be transferred from the home? What are their thoughts on hospitalization and their thoughts on the use of life-sustaining treatments? They can specify the circumstances under which the agent's authority to make their the principal's healthcare decisions for them becomes effective. They can identify preferred clinicians. They can make or refuse to make an anatomical gift, which is an organ donation or other tissue part of the body donated after death. And they can direct disposition of their remains. So some of you may have advanced directives. This is a combination of what in former terms were the healthcare power of attorney and the living will. And you can also, the person can file an advanced directive with the Vermont Advanced Directive Registry, which then makes it available to hospitals and other healthcare providers who might be encountering somebody who is not able to make their own decisions. So that's kind of what an advanced directive is. How do you create one? Well, an adult with capacity can execute an advanced directive at any time. And there's a list in statute of items that may be included in an advanced directive. And then there are certain things that must be included or met for all advanced directives. There has to be a date. It has to be signed by the principal, or if the principal is not able to sign, then signed at the principal's express direction in the principal's presence. And it must be witnessed. The principal must sign the advanced directive in the presence of 2 or more witnesses who are at least 18 years of age, who must sign and affirm that the principal appeared to understand the nature of the document and to be free from duress or undue influence at the time that they signed the advanced directive. A healthcare provider may serve as a witness under the statute, but an agent who's being appointed, so somebody who's being appointed as an agent in the advanced directive cannot sign, nor can the principal's spouse, parent, adult sibling, adult child, or adult grandchild. So those people can be agents. They can be named as someone to make healthcare decisions for the principal, but they cannot be one of the people witnessing the advanced directive as the official witness. All right. There's some additional provisions required when a principal is being admitted to or is a resident of a nursing home or residential care facility, or if they're being admitted to or a patient in a hospital when they're doing their advanced directive. There must be someone who explains the nature and effect of an advanced directive. I think the theory being that this is a person in a more vulnerable situation, and so it's particularly important that there be an impartial person explaining it. So we sometimes refer to these people as apparently paused my screen sharing, did not mean to do that, okay? Sorry. Keep running into issues with the control bar. So for nursing homes and residential care facilities, this explainer must be, and there's a list of one of the types of people that must be providing this explanation. So an ombudsman, a recognized member of the clergy, a Vermont licensed attorney, someone designated by the probate division of the Superior Court. Hospitals have a designated explainer, and that person can also do the explanation in a nursing home. Mental health patient representative, specially trained volunteer, or a clinician who is not an employee of the nursing home or residential care facility. And there's a slightly shorter list for hospitals. So that's the additional explainer that's required. And then there's a number of other provisions in the chapter, but just a few in particular to be aware of. There is a provision on amendment, suspension, and revocation of an advance directive. So principal with capacity, so is able to make their own decisions, may amend, suspend, or revoke all or part of an advance directive. And a principal without capacity may suspend or revoke. They can't amend. They can suspend or revoke all or part of an advance directive. Little asterisk, stay tuned for the Ulysses Clause, which is coming up. In most cases, filing for divorce, annulment, dissolution of a civil union, legal separation, or a relief from abuse order suspends a previous designation of the spouse or opposing party as an agent. So if somebody's filed for divorce, they don't have to worry that they have to immediately update their advance directive to take their soon-to-be ex-spouse off as their agent. And then there's a duty to deliver. Anyone who is in possession of a duly executed advance directive has a duty to deliver it to the principal's healthcare providers if it seems that the terms of the advance directive may apply. All right, so now some other provisions when there's specification for when an advance directive becomes effective. There's a few different ways of setting that up. It can be when the principal's clinician determines that the principal lacks capacity. So now they're not able to make decisions, time for the agent to step in. Or when there's some other circumstance or condition that's specified in the advance directive and that condition or circumstance has been met. Or in some cases, somebody may specify in an advance directive that their advance directive is effective upon when they sign it. As soon as they sign it, the agent is empowered, but not to make decisions unless the principal can't. So an agent's authority to make healthcare decisions stops being effective if the principal regains capacity. So principal with capacity always gets to make the decisions. So the agent's authority can stop when the principal regains capacity, or if there's some circumstance or condition specified in the advance directive that was met and is no longer met, or if the principal suspends or revokes the advance directive itself or the designation of the agent. That means the agent can't make the decisions anymore. Some other provisions, there's certain authorities and obligations for healthcare providers and facilities. Healthcare provider or facility cannot provide healthcare to a patient without capacity, except in an emergency, without first trying to determine whether that patient has an advance directive in effect. And if there is an advance directive in effect, then the provider must follow the agent's instructions in most cases. Healthcare providers and facilities are also directed to develop protocols about advance directives, including asking patients whether they have one, updating their records, and checking the registry. Some more provisions, authority of the agent. When an advance directive is in effect, the agent has the authority to make any healthcare decisions for the principal that the principal could make if the principal had capacity. If the principal has capacity, the principal has concurrent authority with the agent to make healthcare decisions, but if they disagree, the principal's decision is controlling. As far as the agent's decision-making criteria, the agent must make healthcare decisions for the principal by first trying to determine what the principal would have wanted under the circumstances. If that's not possible, then the agent can use their assessment of the principal's best interests. But what they're first supposed to do is figure out what would the principal have wanted under the circumstances. The agent cannot authorize the provision or withholding of healthcare based on the principal's economic status or pre-existing long-term mental or physical disability, and also cannot make decisions based on the agent's own interests, wishes, values, or beliefs. So really trying to do what the principal would want. The agent has the right to medical information. So unless otherwise specified in the advance directive, the agent has the same rights as the principal to get information about the principal's health, participate in meetings about the principal's care, consent to disclosure of healthcare information, and file a complaint on the principal's behalf about a provider or facility. There is immunity for good faith actions. So an agent who makes decisions in good faith pursuant to the terms of an advance directive will not be subject to civil or criminal liability. Also, no civil or criminal liability for a healthcare provider or facility for providing or withholding treatment or services in good faith under the direction of the principal or patient, the provisions of the advance directive, or the consent of the principal, patient, or agent. And there are penalties for providers who fail to follow an advance directive or who make unauthorized access of the registry. They are subject to disciplinary action by their licensing boards. And finally, there's some reciprocity about Vermont's advance directive chapter, not limiting the enforceability of an advance directive that was executed in another state in compliance with that state's law. So we'll recognize one that was validly executed in another state. There are some COVID-era remote witnessing provisions. So those of you who were around here in 2020 may remember there were a number of COVID-related emergency flexibility, regulatory flexibility bills, and some of them had to do specifically with advance directives. As you can imagine, the difficulty in having witnesses physically present to witness a principal signing an advance directive during the, particularly the early days of the pandemic. And so there was concern about being able to create a process for remote witnessing.
How old does an agent have to be?
At least 18.
At least, is there a reason for
Because people under 18 cannot legally consent on their own behalf or anyone else's unless the statute has specifically given them that authority. So we've been talking about in other contexts.
There's a comprehensive assessment of an individual's clinical status and then the care that might follow if they don't have capacity.
that? Same reason for why a witness would have to be 18 years old? Is that the same apply?
Yes, generally, so that they're understanding and appreciating the seriousness of the situation and able to make an assessment that the principals seem to be free from undue influence.
Okay, thank you.
That's that whole age and maturity question, right?
All right, so 18 VSA 9721 was a COVID era witnessing provision that first took effect on June 15th of 2020, was most recently extended through March 31st, 2024. That's why you're looking at this bill now. And there were certain provisions saying an advance directive that was executed in the early days of the pandemic was sort of retroactively deemed valid, even if the principal signed outside the physical presence of witnesses. If the principal and remote witness were known to each other, the remote witness was informed about the role of a witness to an advance directive, and the principal included the witness's name and contact information. So these were kind of blessed after the fact because there were some, I think, pretty serious medical decisions or healthcare decisions being made during that time as the pandemic was starting. And those advance directives were only valid for a short period of time. They were valid until June 30th, 2021. Advance directives that were executed between June 15th and the end of this coming March will be deemed valid even if the principal signed outside the physical presence of one or both witnesses. Again, if the principal and remote witness were known to each other, based on video or phone communication, the remote witness attested that the principal seemed to understand the nature of the document and to be free from duress or undue influence. And the principal included the witness's name and contact information and the nature of their relationship. And unlike the earlier version, these advance directives remain valid, ongoing, unless they are amended, revoked, or suspended. And then there's an additional provision saying that it was okay if the explainer was not physically present, if someone was, that additional explainer required for the hospital or long-term care facility context, as long as the communication was by video or telephone. All right, now we get to the Ulysses Clause.
Oh, neat.
This is my,
Nice.
Yeah.
visual
What movie
image.
is that?
Is that Charleston Heston?
I think it is.
It's probably the
I
Odyssey.
think it's the Odyssey, yes. So here's what the actual Ulysses clause from the Odyssey is. Therefore, take and bind me to the cross piece halfway up the mast. Bind me as I stand upright with a bond so fast that I cannot possibly break away, and lash the rope's ends to the mast itself. If I beg and pray you to set me free, then bind me more tightly still. Now this, as you know, was in the context of the sirens and not during the siren song stuff. Is right. He had his sailors stuff their ears so they would not be lured by the siren
I
song.
remember that.
He was not, but he said, even if I ask to be let go, don't. So the Ulysses clause in the statutes it's not literally what it's called in the language of the statute itself, but it's how we refer to it. And this is a provision saying that an advance directive can contain a provision permitting their agent, if the principal lacks capacity, to authorize or withhold health care over the principal's objection. So that's why we called it the Ulysses clause. Even if the principal says, I don't want that, the advance directive can have been set up in advance to say the agent can consent even over my objection. There are a number of requirements for the Ulysses clause to be valid. The provision must specifically name the agent, so right in that clause, the agent must accept in writing the responsibility of authorizing or withholding health care over the principal's objection in the event that the principal lacks capacity. The principal's clinician also has to sign the provision and affirm that the principal appeared to understand the benefits, risks, and alternatives to the health care being authorized or rejected by the principal in the provision. Another person, one of these explainers, an ombudsman, mental health patient representative, licensed attorney, or probate division designee, must also sign a statement affirming that they have explained the nature and effect of the specific provision to the principal, and the principal appeared to understand the explanation and to be free from duress or undue influence. The provision must specify the treatments to which it applies and include an explicit statement that the principal does or does not want the proposed treatments, even over their own objection at the time treatment is being offered or withheld. It must include an acknowledgement that the principal is knowingly and voluntarily waiving the right to refuse or receive treatment at a time of incapacity and understands that a clinician will determine their capacity. The provisions would take effect when the principal's clinician and a second clinician determine that the principal lacks capacity. And then, if an advance directive contains this Ulysses clause, the agent may, if the principal lacks capacity, make healthcare decisions over the principal's objection, provided those decisions are based on what the principal would have wanted under the circumstances, and the clinicians are directed to follow the agent's instructions. So this is a fairly unique provision in the law. Yes, and then this I have not updated.
Okay.
Yes.
I was a literature major, so can you please tie this into the story of Ulysses for me? That would be really helpful. I don't understand how that is being evoked in this.
So in our quote here, where he's saying, tie me to the mast,
Yeah.
and even if I say, I want you to untie me, do not untie me, no matter what I say.
Right.
So in the advance directive context, the advance directive is the principal in advance saying, hold me to my, hold me to my words now, even if later I say, I want you to not provide me the healthcare treatment, or I want to receive a treatment. Don't listen to me. Hold me to it.
I thank you.
Right.
All right, H 469 as introduced was a short form bill. So don't follow that because we're going to look at the actual bill in our next meeting. But the question that was being posed that the committee had decided, the committee upstairs and then the House decided, was to make remote witnessing provisions permanent and to allow remote witnesses with an additional special process for the Ulysses Clause. And on that note,
Can I just ask, I'm sorry, can I have a follow-up question?
Sure.
If the principal lacks capacity, how can the principal object?
They can't.
they can, I mean, they
Well,
can
they
use
could,
the
but-
words, lacking capacity does not mean you are unable to communicate. It
Okay.
means you are unable to appreciate, the decisions that you are to be making. There's specific definition, and we also have Cindy Bruzzese here, from the Vermont Ethics Network, who you're gonna hear from. And this is her world that she lives in, these kinds of decisions, about, helping providers and others understand, what all of these laws mean.
Okay, thank you.
A quick question that, and then I know that you need to leave and we'll hear from Representative Hyman. The registry, I think
Yes.
next time maybe, or maybe Cindy can help us understand the registry. Because it is a more, it's not a statewide thing, okay?
No, it is a
Goes
national.
outside,
All right.
yeah. Okay, all right. Thank you so much.
Thank you
Good
for
luck.
accommodating my schedule.
Take your phone and get some pictures.
Jen, did you put that slideshow together? Thank you for the visual. I really liked it.
Representative Hyman, thanks for being here. Well, if you have just a few minutes before you have to be up on the floor, and you could share with us, come on up and introduce yourself for the record, and then share with us how the committee looked at this and the importance.
Sure. Representative Hyman, House Human Services. Thank you. The Act 469, as you were just hearing, is a bill that would permanently continue what was a COVID era practice for allowing people to create and change advance directives. The why is during the depths of the pandemic, people were anxious to change their advance directives because people would possibly have to be placed on a ventilator, and it was a new infection. And prior to the change, it was a very lengthy process. Multiple parties would have to meet. It all had to be done through correspondence, by mail, and in person. So the body, wisely at that time, when everything was going online, allowed for audio, visual communication to set up your advance directives and Ulysses Clause. The convenience and commonplace occurrence of advance directives in people's healthcare management and the amount with which it was used showed the legislature the importance in continuing it. Part of the speed with which we put it together and the amount of times it was used, we think it's very important. It does expire March 31st of 2024, so within the next 6-7 weeks. So that's kind of the
That's the timing interest.
Right.
So
exactly.
it takes time to move it along. Yeah.
Now,
Questions?
you've heard some of
Yeah.
the technical side of things, so if there's anything that you would like me to elaborate on, I'd be happy to.
So the committee vote, maybe.
It was 11-0,
Okay, that helps.
yeah,
And then on the floor,
it
whether,
was unanimous.
okay. So we have Senator Gulick and then Senator Williams.
You said it was used, good morning, Senator Hyman, Representative Hyman, how are you?
Fine.
Good. You said that a lot of folks used it during the COVID period.
Not the Ulysses Clause, but
But the-
Advanced
changing events.
Yeah, do you have any sense of how many?
I could try to find out for you. We did this last session, I don't have the.
Oh, we'll get testimony.
Okay.
You're asking the data on.
Yeah, just curious, I mean.
Right, so like I have-
We
I
haven't
use
taken
it
tests
myself.
yet.
I mean, I have an advanced directives, and I chose not to have a ventilator. But I'm assuming I'm gonna be a very old man, but then COVID hit, and people were, young people in their twenties and thirties in Vermont were being placed on ventilators. It was a scary time.
Yeah,
So-
thank you.
I can bring an advanced directive in for you to look at, if you'd like to see it. It won't be filled out.
I highly
The one
recommend
at home
everyone
is
to
filled
have
out.
an advanced directive. I mean, it's pretty easy to do now. I mean, when I set up mine, we had to go to an attorney. And now it's all to be done online. The Ulysses clause is very important. The one thing that is in the bill, that we took testimony on, that I think is very important, and I encourage you to take testimony on as well, is that to enact the Ulysses clause, the first time in person was requested to be required by parties of interest.
At which,
But people who would need one, right? But people who were suffering from any type of malady, whether it be in their brain or in their body or a disability, requested that first one be in person. For them to safeguard for themselves that the process is the right thing for them. That was one of the big changes that I think really not surprised us, but that we didn't think of it, that they asked for us to make sure that the first one. After that, it can be changed.
who was they in that sentence? We can talk.
Sure.
I mean, one of the things that we need, and actually will help, and I've already looked, is at your witness list, because if we're gonna move on this, if we decide to move on this, we're going to need to have the information with alacrity.
That was through the Vermont Psychiatric Survivors. We also met with, of course, Ledge Council, Vermont Ethics Network, Legal Aid, Vermont Healthcare Association, VBA Probate and Trust Law, and the Policy Director of Alzheimer's Association.
That's good.
Those
Thank you.
were some of the, so,
Senator
Did
Reed.
anybody oppose it?
no. The
No
real,
group came out and said-
well, once, like, what was the discussion? Capacity. Once people understand the difference between capacity and communication. Once that distinction was really drawn out, people can get that you can be incapacitated, but not unconscious, right? You can go from one state to another. For example, one of the things in my own research in doing the bill, there are certain medicines that people can take that they are off them on the body when they take this. And if they don't take their medicine, it could be as significant as they may have to be institutionalized.
They may be,
Institutionalized for great lengths of time at great expense. And all they're saying is, no, I don't want I don't want that medicine. But they do want the medicine, they don't have capacity to make that decision. But they know that when they do have capacity, at some time in the future, if I forget my medicine a couple of days or something happens, this may occur. That's why the need for the advanced directive in that type of situation, or of course, Alzheimer's dementia patients as well.
Thank you. Good. Okay. Good. Senator Williams.
Is there any requirement for federal hospitals, like the VA, to ask for advanced directive? Because I know I get treatment at the VA clinics and they always ask me to have one on file.
Sure.
So is this Vermont state law required them to have?
You are not required to
Okay.
have the
Okay.
Ulysses clause in an advanced directive. It is an optional.
Okay.
Right
They
now,
always ask me if I have one.
and I highly recommend to everyone
I think
to
I've
have.
given it to them
to
at
have
least 3 times.
The Ulysses clause is pretty specific.
Okay.
So
Who's required to secure this? I mean, if I give it to the VA clinic,
So, yeah, so that's the question about the registry and
Okay.
where it is. So we'll get testimony
Okay.
on that.
correct. So when
Yeah.
you go to, for example, UVM, you'll take the testimony.
Yeah, no, we'll get testimony on it, and, this is great, this is a great introduction for us, and we're gonna talk with Cindy Bruzzese, next, and she's gonna,
She helped me as well very much.
I
She's
know
extremely
she will,
knowledgeable.
yeah.
Nice to see you.
She's an expert in this
Yes.
area. It's great. Well, we're good, I
Okay.
think, yeah, thank you, great,
Thank you.
thank you. Do you wanna come up, Cindy? I mean, you've heard some of the questions, and I know you have a thorough understanding of what this is, so. And so we've worked through so many different, I can't remember the first year we started on this whole thing.
It's a long time ago now,
Yeah, it's good.
probably 2009, when I
Something
first
like that.
came to the Ethics
Yeah.
Network, yeah, a long time ago. Yeah.
So, maybe you could help us understand, I think the issue around capacity is important, and then if you have, could help us understand the registry itself and how this all fits together with, an individual, you know, starts with an advanced directive, and then where does it go, and how does it affect decision-making, and then the Ulysses clause. Can you do that?
Sure.
That's great.
So just for the record, I'm Cindy Bruzzese. I'm the executive director, and I'm a clinical ethicist at the Vermont Ethics Network. I also work part-time at UVM Medical Center on staff there as a clinical ethicist, seeing patients in clinical settings and helping providers, patients, and families work through complicated decision-making in the course of just clinical encounters, which is there's just bound to be ethical uncertainty in medicine, particularly now as medicine is increasingly more complex and people are living longer with more chronic illnesses. So it doesn't mean anybody did anything wrong. It's really just like, ooh, we don't know how to proceed here. We're unsure. So I also chair the ethics committee for the Department of Disabilities, Aging, and Independent Living. So I work with people who are under public guardianship and help them navigate ethical decision-making for people with developmental disabilities and also elders who are under public guardianship. And I direct the statewide task force on palliative care. So I wear a multitude of hats, lots of overlap between all of those things. And as Senator Lyon said, I've been before this committee and House Human Services over the years since I started my work at the Ethics Network talking about medical decision-making. And I just want to extend my gratitude to all of you and to the legislature for having a really long history of being very supportive of patient self-determination. And that is, in essence, what advanced directives are all about. It's about how do we help people to plan for the unexpected, because sudden accident and illness can happen to anyone at any time, and you may not be able to make decisions for yourself. And so how do we make sure that the care and treatment that's being provided to you aligns with what matters most to you? And that is very individualized, right? Because different people have different values, people have different priorities, different people think differently about being in the hospital or having, life-sustaining treatment being provided to them. So it's really important to provide good quality care, that we're not just doing things to people, but we're doing things for people that are in alignment with what they value most. And that's really what underpins advanced directives. We've had a campaign for a number of years to sort of get advanced directives kind of out of this legal mindset, which makes everyone panic, and think more about it in terms of who's your person, who do you trust, who knows you well and can make decisions for you, and then what's the plan? What do they need to know in order to be a good advocate for you in that healthcare setting when you can't advocate for yourself? When COVID hit, so people have been doing advanced directives for decades, right? This all came about way back when we had Karen Ann Quinlan and Nancy Cruzan and Terry Schiavo and those young women who before catastrophic events were not able to speak for themselves, and their stories obviously very painfully were played out in law. And that's why we have advanced directives and Patient Self-Determination Act at the federal level. So to your question, everybody, every healthcare provider, every hospital has to ask you,
Okay,
do you have an advanced directive?
every hospital in Vermont.
In the whole country.
Oh, okay,
It's federal. So it's a CMS requirement. The Centers for
Oh,
Medicaid and
okay.
Medicare require hospitals and healthcare providers at your annual visit to ask you, do you have an advanced directive? They can't make you have one because it's purely a choice, but they do need to ask you if you have one. And then and in hospitals, in our case, you have to offer people the opportunity to get more information. If they say, I don't have one, what is that? then we need to support people to get the information. So that's something that has to be done, and that's why they keep asking you every single time you show up.
Okay.
Because we want to know, that's how we
So
try.
my question is, how do they secure it? I mean, who's
It
providing
should-
for, responsible for security?
You should provide it to them. You can also provide it to what we have in Vermont is a registry, which I can talk about later. And then they should scan it or upload it into your medical record.
Okay.
But they're probably still gonna ask you about it because advanced directives are not a one and done.
Right.
Because the document I had in my thirties when my kids
And it can
were
change.
younger has changed quite a bit now that I'm approaching
Mine too.
60, right? So goals change, values change, people change, your circle of friends and family changes, so they get updated. That's why they have to keep asking you, and they want to make sure they have the most current document.
Okay.
So when COVID hit, obviously people started to think about, well, wait a minute, what does my document say right now about end of life or serious illness? Because maybe I don't want it to say what it says, because maybe I could recover from COVID. So maybe, you know, if it was a massive stroke that I can't recover from, or some other calamity, then my document should stay the way it is. But if it's COVID and they can treat it and put me on a ventilator for a short time, well, yeah, I do want that. So we started to see a lot of people requesting amendments. They wanted to make amendments to their advanced directives and make sure they were in the registry. The registry became very important because people weren't going in person, making copies of documents and handing them out. They only had one copy and they sent it to the registry because they knew hospitals needed to check. And so that's kind of, and then we quickly learned, oh, they can't update anything because you have to complete a new document and have it signed and witnessed. Nobody could sign and witness anything because they couldn't get in the physical presence of the people who could be their witnesses, because the little pods that we were all in were with our families. And as Jen said, they can't be witnesses to your document. So all of a sudden we had a problem. So rightly, y'all decided we need to fix this. And so we started doing a lot more through telehealth and telemedicine. And that's just really been now, I think, become more standard of care.
I always ask them, yeah, I've got one registered with you.
Yeah,
Where, you
they
don't
should
know?
be checking.
Okay, so I'm wondering who the heck is keeping track of it?
Well, they should be checking the
I mean,
registry.
that's a legal document.
Yes, it is.
They should have a good electronic.
Yeah.
Communication system that you can log into.
They should, and I'm working right now with UVM to help improve their systems, just because of how large that institution is. It's a teaching hospital. There's a lot of turnover because you have residents that cycle in and cycle out and medical students that cycle in and cycle out. And so it's hard to keep track of things. We just embedded the ability to check the registry with single sign-on. So you don't have to, so when they log into that electronic medical record, they can connect directly to the registry through that and check. So that only took me 4 years. So the wheels turn slow in large bureaucracies, but we did finally get there. So it should be easier now within the whole UVM Health Network. So as it relates to 469, really the goal, I think, of this bill is, in my mind, threefold. One is, as you know, to make this permanent witnessing and explaining, to make that permanent. So we don't have to keep coming back every year because of the next, you know, pandemic-like thing, RSV, flu A, flu B, whatever it is. We just make that permanent through the use of live interactive audio, video, or phone. So there's the ability for people to do this over the phone. To allow for digital signing. Right now, we only have, you know, like regular physical signing, which means people need to print their document once it's completed. Even if they filled it all out online, they have to print it, then they have to get physical signatures, then they have to scan it back in so they can send it out. That is limiting for people that don't have access to printers, computers, don't have the technological capabilities to do. So in order, but they could do it in the hospital with an iPad with the support of their home health aide. I mean, they could do it at home with home health support, whatever. So we think adding the ability to do it through digital e-signature would increase access to some folks. I think it would also promote younger people to do this because they don't do anything on paper. I mean, my experience with my own kids are like, what are we doing printing? Why are you printing that, Mom? You know, they think I'm crazy.
Well, they're not taught cursive anymore, so gee.
Yeah, so they could do it all electronically with digital signature and then save it to their devices and then send it to the registry, send it to their doctor's office, send it to the hospital medical records. So I think that's the goal. This, originally, I think people thought of advanced directives as end of life, older person's need. It's for anyone 18 years of age or older. Anyone who's 18 who's their own decision maker should have an advanced directive, because just like those right to die cases that were the big ones that are the reason we have advanced directives, those were all young women in their 20s. These were not people who were 85 with some terminal illness. So that's the other reason. You could still do it the old way. You could still print and do all those things, but we want to at least allow for digital signature. And then as you've been talking about the Ulysses Clause, which a lot of people have a lot of questions about and are confused about, part of the goal of this bill is to clarify the process for completing a Ulysses Clause. The Ethics Network and the Palliative Care Task Force did recommend that we allow the whole process of Ulysses Clause to be done remotely from start to finish, whether it's your first time or not. However, there were some people that were not in favor of that provision and wanted there to at least be one in person, because you're waiving a fundamental right. Everyone has the right to refuse, even if they lack capacity and don't understand what the implications are of their refusal. That is a really confusing thing, even for healthcare providers, and probably the #1 ethics call that I get. This person is confused, they're delirious, they were not letting us, can we treat them anyway? No, not unless it's an emergency. And that is very hard for healthcare providers to sort of get their brain around, because they're like, they don't understand. They're not able to understand what the implications are of their refusal. And I said, I know. But they retain the right in ethics to their bodily integrity. Imagine how scary it would be if you didn't understand what was going on, you were afraid of everyone, and the one thing that they did is laid hands on you and started jabbing you with needles. Like, really scary. So unless it's an emergency, and Vermont law and the advanced directive statutes defines what that emergency is, which is if failure to provide the health care within 24 hours would result in irreversible bodily injury or death. So you all have set the threshold for when you can intrude on that person's bodily autonomy and treat them over their objection. And that's if you've got to save their life. But short of that, you got to try other ways to connect with that individual and to get them to at least agree or not refuse. So the Ulysses Clause is the tool that someone could put in place in advance to say, do it anyway, even if it's not an emergency. And I think historically it predates me, but my understanding is that historically this was really designed for people with psychiatric illness. You can imagine people who are on their antipsychotics who start to feel really great and then say, I don't really think I need these anymore. I'm doing so much better. And so they stop taking their medications. And then after a few weeks go by, and maybe a month goes by, and then their psychosis, their schizophrenia, whatever it is, comes back, and they're now acutely psychotic and an imminent threat to harm self or others. So they end up in the hospital emergency department because they're in acute distress, right, because of their mental illness, and they're not allowing anyone to give them their medications. So we have a very separate process in Vermont for those folks in order to hold them, to try to stabilize them, and then eventually maybe to treat them or place them involuntarily in an involuntary hospitalization. And so that all unfolds over weeks to months. If a person knew that this was kind of a pattern for them, they've done this before, they could say, wait a minute, I don't want to wait weeks to months to be on my path to wellness. I'm going to put a provision in my advanced directive that says, listen, I'm of sound mind right now. This is what's important to me. These meds have worked. These meds have not worked. If I get into this situation again, I'm authorizing my agent to consent to give me these medications, even if I'm refusing. That skips the whole long process of going through court hearings and all these other things, and they can immediately get on a path to wellness. Great for some people. who've had that as in their history, a really useful tool. More so being used now, I think, for people with dementia, even more so than people with mental illness, because dementias are unfolding for some folks with profound behavioral disturbance. Meaning they look like a psychotic patient, even though it's not from a mental illness, it's from the fact that their brain is failing due to a a somatic medical problem. And so these folks are also now implementing Ulysses clauses for themselves because they're taking medications that are keeping them stable in home. And what we're seeing in the hospital is they've got everything in place but the Ulysses clause. And their agent without a Ulysses clause cannot consent to giving them medications when they are refusing. And so some of these folks are getting stuck in the hospital because there's no place for them in long-term care, there's a shortage of beds, and it's the worst possible place for a person with dementia to be in the hospital. It's just a terrible spot because it's too much, it's too chaotic. So this has become increasingly, which is why the Alzheimer's Association also testified in the House last year, because it's becoming an increasingly important tool for older people with dementia.
DNR.
DNR is a completely different thing.
Because like, but going back one step to the like emergency management.
Right.
If I've actually heard of somebody having it tattooed across their chest, do not resuscitate, DNR.
Yeah,
So-
unfortunately, that's not quite good enough as
Okay.
an informed consent,
It's
but.
just a tattoo.
DNR orders are a completely different tool in what I would call the advanced care planning continuum. So advanced care planning is thinking about having conversations with people who know you well and making a plan for future healthcare needs. Then we have tools to document those plans. Advanced directives being one of the most important tools, I think, because it names the decision maker and gives a good overview of the plan. Another tool is DNR orders, which are medical orders. So they are completed by a clinician in conversation with the patient directly or their decision maker, but that's a different tool. So this bill really is only aimed at addressing the advanced directive documents and clarifying some of those provisions that allow people to make a plan and the scope of that plan. So hopefully, does that help?
Yeah, it's great, really good.
Yeah.
And it's in language understood. It's really good.
Yeah, and then the registry is another tool that we have, and that is something that Vermont set up. We purchase as a state, Vermont purchases space in the US Living Will Registry, which is a national database. So we pay for a section of that electronic storage space for all Vermonters who choose to submit their document there. And so people can voluntarily send their documents there, and then there are rules around what hospitals and healthcare providers need to do in order to check the registry if a person walks through the door that doesn't have the capacity to speak for themselves. We want to check, and it's not an emergency. If it's an emergency, we're going to stabilize the patient and figure it out. We're going to get them stable and then figure out what the plan should be. But if it's not an emergency and they can't make decisions for themselves, we're going to look to see if they have a document, and if they do, then we need to see who's their decision maker and what does it say about the plan, and we have a responsibility at hospitals to try to implement the plan to the degree that it applies, because people make advanced directives about certain scenarios and then something else completely different happens, and so there's no crystal ball, but we do our best.
While you're talking, I'm getting all these memories are coming about around about if someone's in another state, how do you get in touch with their agent and what's required of a physician and how long does it take? I mean, big deal.
So that I was gonna actually ask about another state. So if I'm traveling and get into a bad car accident, God forbid, in Ohio or whatever,
Right.
can the hospital there get into the registry, even in the Vermont section of the registry, and see an advanced directive?
Yes, so every person who has, so every state has an advanced directive law of some sort. So this is not unique to Vermont that we have advanced directives, every state has them. Every state they may call them a decision maker, we call it a healthcare agent. Some places call them a healthcare proxy. Some people still call them durable powers of attorney for healthcare, but the language is a little bit different, but it all speaks to the same general premise that we have a responsibility to respect what people say when they can make decisions for themselves, and then to look to any planning documents that they have to give us guidance when they can't. And so in Vermont, we would honor any other states, and likewise, they would honor ours. Because we have a registry, once you submit your document, you get a wallet ID card that you can carry on your person that says, I'm registered, my documents in the Vermont Advanced Directive Registry, this is my emergency contact person and their phone number, and this is how to access the registry. So that wallet ID card can then be used by anyone who has it, who can then look up your document and say, oh, okay, who is this person? The other thing is there's a toll-free number on that card, and the service that Vermont contracts with the vendor, they provide 24/7 access. So the hospital could actually just not even bother looking it up, saying, oh, I see this person, call, hey, this person's been admitted to our hospital, we need to see their document, and they will fax that document directly to a provider at that particular healthcare facility so that they can have the document there. So yes, it's available no matter where you're traveling, at least in the United States. The laws in Europe are all a little bit different. They don't place as high a premium on autonomy as we do in this country. But nonetheless, because it's web-based, it could be accessed from anywhere.
Okay, great.
Any other questions for
Thank you.
Cindy? So, wow, thank you, and thanks for being here and
Sure.
available at short notice. Can we get some testimony from you in writing? And then as we go through the bill, it will be really important to have you stay connected with us. We'll get some testimony put up fairly soon, but not
Sure.
next week, possibly. I think it's, I figure, I'll look and we'll see when it is, but we can do that.
Sure,
Yeah, thank you.
of course,
And thanks for your work.
of course,
I know.
anytime.
Things have changed radically since my graduate medical ethics course, I think, so.
Yeah, it's been incredibly busy. I'm constantly in, who knew, everyone thought of ethics as like this philosophical discipline where we would sit around and think about big questions and
Daniel
not solve anything.
Callahan, yes.
And now it's applied ethics. I think COVID has really made people see that, wow, you need to be able to apply these kinds of concepts to real situations in real time and make a decision. So
Right.
ethicists.
And just thinking about
really
who
busy.
your agent is, I mean, it's not simple. You think, oh, my agent, oh, my oldest daughter, my youngest son, whatever it is, it's just not simple.
It's not simple,
No.
and medicine's not simple.
No.
So it's a lot
No.
of advocacy and
Yeah.
asking clinicians to take a pause if we don't understand what they're saying and say it in plain English and help us understand what the future looks like. It's complicated, but I'll bring forms when I come
Oh,
next
wait,
time.
we understand that. It is complicated. But I also just want to say thank you because you have presented it so clearly and in English for us, language that is understandable by anyone. It's not in the upper level ethical autonomy benefit. Yeah, okay. Thank you.
And I'll bring advanced directives when I come next time, so you'll have copies
Okay,
here. I'll
that'd
bring
be
the
good.
forms.
Everybody can have one.
Yeah,
All right.
I couldn't do that. I mean, that's part of my job, right, to make sure we all try to have advanced directives, so. I'm usually have a bag full of them everywhere I go.
But we can do it on the registry too, right?
You can do it, right now, you can upload the documents on the Vermont Ethics Network or the Department of Health that they link to us, so it's all the same form. You can upload the documents, and then download it to your computer, you can fill it in online, but right now, you still would have to print it out and have it signed in witness, and then scan it back in as a PDF. You still have to do it that way until this bill passes, assuming that it passes. Then you would have the ability to do e-signature once we get that functional.
Great.
Thank you.
Thank
All right,
you.
terrific, thanks.
Thank you.
This is good. So this bill does have a little time frame to it. We'll put some testimony on and try to understand it as much as we can. And then, unless I hear differently, we'll move it forward. I think it sounds like something that is useful to all of us. So what I'm going to suggest is, let me go through some of the things we're looking at next week, and then, thank you, Cindy.
Thank you.
Thank you.
Have a nice weekend.
We'll
You too.
we'll just talk about next week a little bit, and then I want to go offline to talk about some, field trip and process stuff. So, next week, we're gonna continue work on S-192 and, S-197 and S-187. So 192 is the forensic facility work that we've been doing with, intellectual disabilities and mental health. S-197 is the PFAS bill. And there's some language that we've asked for on each of these. So, we haven't asked for new language on 192, but we'll go through and try and do some markup on that bill, as well as 197 PFAS. And there will be some new language that Katie's putting together on our sections around education and so on with the Department of Health. Then, we're going to look at S-187, which is the sunscreen application in schools. Look at that one. That just came to us, and whether we have time to actually do a lot on that one.
Sunscreen?
What is, can you tell us? what
Sunscreen in schools, it allows children to apply sunscreen in schools.
that- Otherwise, they're not allowed to? They're
So
not
we'll
allowed,
learn about that.
they're not allowed to put
We'll learn
sunscreen.
about that, and there's some kids who actually need it.
I
If
don't
they're
believe
12
that.
years old, they can make their own sunscreen.
So, okay, then we're also, if we have,
At least we're offline.
I will tell you, we're not off yet. We're still live. We'll come back to that when we.
So 192, 197, 187, is that
Yeah,
right?
and then we're also going to, we'll take a look at the, psilocybin bill that people have been interested in. We'll be looking at 192 for markup, and we're gonna go back and see what is left in 151. Jen's putting together a bill for 151, S-151, the healthcare, stuff. We'll also be looking at S-186, which are the recovery, centers, community centers. And next week, Recovery Day happens the day before we look at that, I think. Then we'll also be looking at this mental health response and going back, and then, we'll come back to 469 later in the week. So now, so those are the things that we'll continue work on, and we'll try to get to markup and get through, especially on 192, because we have been working on that one. It's pretty complicated. So, yeah.
Could you tell me what the most recent draft number of that one is?
I think it's 6.1. It's the one that we had the other day.
It's 6.1, so I
I don't know. I could be wrong, but
No,
I
I think
pretty
it's
much
6.1.
think it's
because I keep
6.1.
getting them printed and then there's a new draft and then.
Well, yeah, Katie keeps making
Yeah,
technical
And
edits.
that's why
for
I
us.
asked her to stop,
Yeah.
so that we could have
Right.
a steady draft to just review the
Yeah.
whole thing.
6.1.
So Kiki, would you mind getting me a copy of that? Because
All right,
You
so
printed
we can do that.
1.5 and it was
No, that's
already old.
Yeah. we
I'll
don't
take
want-
one too, please.
Thank you.
Can I say something about the psilocybin bill real quick, as a sponsor?
Yeah.
If we have the opportunity, I think one thing that could be done with that bill is to remove the decrim piece and just focus on putting together the advisory.
Yeah, so I think that's a good thing for the
Yeah.
sponsor to, present when we pick the bill up.
Okay.
That'd be great. So, yeah, we'll do all that next week.
what
So it's
number
just a
now?
heads up,
What's
114. So this is a heads up that, is it 114 or 2?
Yeah, it's 114.
Yeah,
And what is 197?
and, and so just a heads up that those are some of the bills we're looking at next week. As you know, the agenda is very friable. It changes, so, but that's where we're going. So now